Childbirth is traumatic no matter how you deliver. While society often frames it as a purely beautiful experience, that narrative can obscure the raw and sometimes terrifying reality of what a mother's body endures. For some, the journey of bringing life into the world abruptly becomes a fight to preserve their own. Today, we'll be looking at some of the most devastating childbirth implications based on our understanding and expertise. These conditions can develop with little warning and require immediate medical intervention to save a mother's life. They include postpartum hemorrhage, a sudden and excessive bleed after delivery, the dangerous hypertensive disorders of preeclampsia and eclampsia, the life-threatening liver and blood clotting disorder known as HALLP syndrome, and placenta accreta, where the placenta attaches too deeply into the uterine wall. Understanding these critical conditions is, well, it's incredibly important for anyone involved in pregnancy or supporting someone through it. We're going to dive into this complex landscape, try to bring some clarity to these urgent situations because really the more we know, the better prepared we can all be. So let's start with the immediate aftermath of childbirth, focusing on a condition that can be truly frightening. Number one, postpartum hemorrhage, often called PPH. Can you break down for us what exactly PPH is and why it's such a significant and urgent concern?
Absolutely. Postpartum hemorrhage, or PPH, is essentially excessive bleeding that happens after childbirth.
Yeah.
It's a really serious and potentially life-threatening complication that demands immediate attention from medical professionals. When we define it, we're talking about losing more than 1 liter, which is, roughly 33 fluid ounces of blood within 24 hours of delivery. And that's regardless of whether it was a vaginal birth or a C-section. But it's not just about the volume of blood lost. It's also diagnosed if any amount of blood loss leads to signs of what we call hypovolemia.
Hypovolemia.
Yeah, it means there's too little blood circulating in the body. So you might see noticeable changes in vital signs, like a really rapid heart rate or a sudden drop in blood pressure. That tells us the body is struggling to cope with the blood loss, making it a critical situation. It's important to understand that PPH can happen at different times too. We generally categorize it into 2 types. First is primary PPH. This occurs within the first 24 hours after delivery, and honestly, this is the most common time for it to show up. Then there's secondary or late PPH, which can happen anywhere from 24 hours up to a full 12 weeks after the baby's born.
12 weeks. Wow.
Exactly.
Yeah,
Now,
like-
while hearing about excessive bleeding is understandably alarming, it's worth noting that PPH affects about, say, 1% to 5% of deliveries. And the good news is, with prompt and effective medical intervention, most cases are not life-threatening. The key really is swift action.
That makes a lot of sense. So, okay, if the body is designed to stop bleeding after birth, what goes wrong? What are the typical culprits behind PPH?
That's an excellent question, and it's often more complex than just one single cause. We frequently categorize the underlying reasons for PPH using what we call the 4 T's. It just helps us remember the main areas where problems can pop up. The first T is tone, and this refers to uterine atony. This is by far the most common cause. It accounts for a staggering 80% of PPH cases.
80%.
Yeah, 80. Think about it. After the baby and the placenta are delivered, the uterus needs to contract really, really strongly. These contractions are absolutely vital because they act like a natural clamp, compressing all those blood vessels where the placenta was attached. If these uterine muscles don't contract effectively, if they're kind of lazy or atonic, as we say, those blood vessels just stay open and keep bleeding.
What makes them lazy?
Several things can contribute to a weak uterine tone. Maybe a very prolonged, or conversely, an unusually rapid labor. An overstretched uterus can be a factor perhaps from carrying multiples, like twins or triplets, or if the baby was particularly large, or even if there was just too much amniotic fluid. Also, prolonged use of certain medications to help contractions, ironically, or even uterine infections, can weaken these crucial muscles.
Okay, Tone, what's the next T?
The second T stands for trauma. This is about any physical damage to the birth canal that occurs during the delivery itself. So this could be tears in the cervix or in the vagina or in the perineum, that area between the vagina and rectum. Sometimes blood can collect in a hidden space, creating what we call a hematoma, often in the vulva or vagina.
A hidden bleed?
Exactly. These hematomas might not be immediately obvious, but they can continue to bleed and expand for hours or even days, causing significant pain and, of course, blood loss. Plus, deliveries that involve instruments like forceps or a vacuum extractor or any C-section inherently increase the risk of trauma-related bleeding because of incisions and potential injury to blood vessels.
Okay, so tone, trauma. What's third?
Next up is tissue. This refers specifically to retained placental tissue. After delivery, the whole placenta is supposed to detach completely and come out. But if parts of it, or sometimes even the entire thing, remain stuck to the uterine wall, the uterus just cannot contract effectively to stop the bleeding. It's
Yep.
like trying to squeeze a sponge tightly with something hard stuck inside it,
Mm.
This category also includes more complex issues like abnormal implantation of the placenta, which we'll actually touch on later, where the placenta has grown too deeply into the uterine wall and simply can't detach.
And the last T.
And finally, the fourth T is thrombin. This covers blood clotting conditions. If a person has a pre-existing bleeding disorder or any condition that affects their blood's ability to clot normally, they're naturally at a much higher risk for PPH. This could include conditions like von Willebrand disease, for example, but also some very serious conditions can develop during pregnancy that mess with clotting, like disseminated intravascular coagulation or DIC.
PIC sounds serious.
It is. DIC is particularly dangerous because the body basically uses up all its clotting factors way too quickly, leading to widespread bleeding. It can actually be triggered by other obstetric emergencies, like a placenta separating too early or a severe infection.
That's a very clear breakdown of the 4 Ts. So with those causes in mind, what are the most important signs and warning signals that someone experiencing PPH or their loved ones should be looking out for? What really flags it as a problem?
Right. The most common symptom, and often the first thing people notice, is persistent and excessive vaginal bleeding. We're talking about soaking through more than one large sanitary pad in an hour, or passing big blood clots. Anything larger than, say, a golf ball is definitely a red flag and needs immediate attention.
Okay. Heavy bleeding, large clots. What else?
But it's crucial to understand that PPH isn't always just obvious, heavy bleeding. There are other vital signs that can indicate a significant issue, even if the bleeding doesn't seem that dramatic at first glance. For instance, the person might start feeling really dizzy, lightheaded, or faint. They might experience blurred vision. An increased heart rate is a really significant indicator the body is trying hard to compensate for the decreasing blood volume. On the clinical side, a noticeable drop in the red blood cell count, which we see in lab tests, is also a key sign. Other physical signs can include pale or clammy skin, indicating poor circulation. And if hematoma is forming, like we mentioned under trauma, they might feel increasing pain and notice swelling in the vaginal or perineal area.
And you said it can happen later.
Yes, and what's particularly challenging about PPH is that it can sometimes occur without any obvious symptoms until after someone has already left the hospital. This is why we really emphasize the absolute urgency of contacting a medical professional immediately if any of these symptoms appear in the days or weeks following delivery. Prompt action can truly make all the difference.
That's a powerful reminder about vigilance after going home.
Mm.
So who is most susceptible to PPH? Are there specific factors that put someone at a higher risk, even though you said it can affect anyone?
That's right, it can happen to anyone, which is a crucial point, in fact. About 40% of cases occur without any known risk factors at all. But yes, there are several situations that definitely increase in individual susceptibility. A past history is a big one. Having had PPH in a previous pregnancy significantly increases the risk for future deliveries. Placenta issues are also major risk factors. This includes things like placenta previa, where the placenta covers the cervix, or placental abruption, where it separates from the uterine wall too early. And also, if the placenta grows too deeply into the uterine wall, that condition we'll discuss later that poses a major risk.
What about the labor itself?
Yes, specific factors related to labor and delivery matter. General anesthesia, for instance, can contribute to uterine atony. Also, prolonged use of medications designed to stop labor contractions can sometimes lead to the uterus being, well, tired. Both very long labors and very quick labors can increase the risk. Using instruments like forceps or a vacuum during delivery, significant vaginal tearing, or having a C-section delivery also elevate the likelihood, usually due to the trauma aspect.
And other health stuff.
Absolutely. Other health conditions play a role. This includes pre-existing blood clotting disorders or certain pregnancy-induced conditions that impact clotting, like HELLP syndrome, which we'll get into shortly. Infections in the amniotic sac, obesity, and advanced maternal age are also recognized contributing factors. And finally, characteristics of the uterus itself can heighten the risk. An overstretched uterus, say from carrying multiples, a very large baby, or having too much amniotic fluid, just makes it harder for the uterus to contract effectively after birth. Also surprisingly, having had 5 or more previous deliveries can increase the risk, as the uterine muscle might lose some of its tone over time.
Okay, so if someone starts showing these signs, how do medical professionals identify PPH quickly, and what urgent actions are taken to, well, save a mother's life?
Right, when PPH is suspected, rapid identification and intervention are absolutely paramount. The initial diagnosis usually invites a quick physical examination, where we estimate the blood loss. This can be done by carefully weighing blood-soaked pads and sponges. It sounds basic, but it's effective. Continuous and vigilant monitoring of vital signs, pulse, blood pressure, oxygen saturation is crucial. Significant changes here can signal serious blood loss, even in people who might initially seem okay because they're compensating well. Blood tests are also done urgently to check red blood cell counts, hemoglobin levels, and clotting factors. Sometimes an ultrasound might be used to look for any retained placental fragments or internal bleeding that isn't obvious.
And the actions, what happens right away?
The primary goal is urgent intervention to stop the bleeding and stabilize the patient. Several immediate actions are typically taken. Uterine massage is often the very first step, literally manually massaging the uterus to help it contract. Then, medications are given quickly to stimulate uterine contractions. Oxytocin is almost always the first-line drug, given intravenously right after delivery as a preventative, too, often. If that's not enough, other powerful meds like methylorganovine, carboprost, or misoprostol might be used. We also have tranexamic acid, a medication that helps blood clot better. It's been shown to significantly reduce the likelihood of death if given within 3 hours of the bleeding starting.
What if it's retained tissue or tears?
Good point. If retained placental tissue is suspected, it has to be removed manually or with a procedure to allow the uterus to contract properly. Any tears in the vagina, cervix, or uterus are promptly repaired with stitches. Sometimes, specific techniques like applying pressure inside the uterus using a special catheter or an inflatable balloon can help compress bleeding vessels directly. In more severe cases, we might need procedures to stop the blood supply to the uterus temporarily, or, very commonly, blood transfusions and intravenous fluids become essential to replace lost blood volume and prevent shock.
And the last resort.
In very rare, severe cases where nothing else works and the bleeding is still life-threatening, a laparotomy, which is abdominal surgery to find and stop the bleeding, or even a hysterectomy, the surgical removal of the uterus, might be necessary to save the individual's life. It's a profound step, but sometimes absolutely medically required.
That's a comprehensive look at a truly critical situation. Okay, for anyone listening, let's imagine this scenario. You're home a few days after giving birth, feeling okay, and then you suddenly notice unusually heavy bleeding, way more than you expected, or you start feeling really dizzy and weak. What is the absolute first thing you should do, and why is acting so quickly just so critical? Tell us what you would do in the comments below.
In that situation, my immediate advice, honestly, would be to call for emergency services, call 911 or your local equivalent, or head directly to the nearest emergency room. Don't waste time trying to call your doctor's office, especially if it's after hours or you can't get through right away. The rapid loss of blood and PPH can lead to shock incredibly quickly, and every single minute counts. Getting to a place with a full medical team ready to intervene is the top priority.
I completely agree that immediate medical help is vital. My thought process would also be getting help without any delay. However, I might also suggest, if it's possible, trying to stay calm, easier said than done, I know lying down, and maybe having someone else with you to monitor your symptoms while you make that emergency call or arrange transport. It's about securing that professional help urgently, but also trying to manage the immediate situation as best you can until help arrives. But the absolute main point, as you said, is don't delay. Get help. Now let's shift our focus a bit to another critical condition. This one often begins earlier in pregnancy, though its full severity might not be obvious until later or even like PPH after delivery. Let's talk about number 2, preeclampsia. Many people have heard this term, but what exactly is it and how does it fundamentally affect a pregnancy?
Right, preeclampsia. It's a serious blood pressure condition that typically develops during pregnancy, usually after the 20-week mark. Its defining characteristics are high blood pressure readings specifically, consistently 490 mmHg or higher, and the presence of significant levels of protein in the urine. That protein tells us the kidneys are being affected. What's particularly concerning about preeclampsia is that it doesn't just impact blood pressure. It can actually affect other vital organs throughout the body. The liver, the brain, even the blood clotting system can get involved.
And it can happen after birth, too.
Yes. Crucially, while it most commonly occurs later in pregnancy, it can also appear unexpectedly after the baby is born. This is known as postpartum preeclampsia, and it can be just as dangerous. This condition complicates about 5% to 8% of all births here in the United States, making it a pretty common and significant concern. It's also a frequent reason for premature deliveries. And importantly, the only definitive way to actually resolve preeclampsia is the delivery of the baby in the placenta. Until then, it's all about careful management and vigilance.
Since you mentioned it can sometimes be subtle, what are the most common signs and symptoms that someone might be experiencing preeclampsia? What should expectant parents really be aware of?
You're right, the symptoms can be subtle initially, and some individuals might not even have noticeable symptoms at all, especially early on. Often, the very first indications are actually picked up during routine prenatal appointments. Those consistently high blood pressure readings and the detection of protein in the urine during a simple dipstick test. Beyond that, a sudden rapid weight gain and noticeable swelling, what we call edema, particularly in the hands, face, and ankles due to water retention, can be early clues.
And more severe signs?
As the condition progresses, or in more severe cases, other more alarming symptoms tend to emerge. These include severe, persistent headaches that don't get better with typical pain relievers and various visual disturbances. People might report blurry vision, seeing spots or flashing lights, or even, frighteningly, temporary vision loss. Upper right abdominal pain is another critical warning sign, often described as a sharp, intense ache right under the ribs, which is usually related to liver involvement. Persistent nausea, severe vomiting, dizziness, trouble breathing, or confusion are also really important signals to watch out for. A decrease in urine output can also be a sign that the kidneys aren't functioning properly. In cases we classify as severe preeclampsia, blood pressure readings are typically much higher, 60 to 100 milliamp 10 milliliters a year, or even higher, and there will be clearer laboratory signs of kidney or liver damage, very low platelet levels, or sometimes fluid building up in the lungs.
That helps paint a clearer picture of what to look for. So why does preeclampsia happen? What do we understand about its origins, and are there certain factors that put someone more at risk?
That's the million-dollar question, really. The precise cause of preeclampsia isn't entirely clear, and it's a huge area of ongoing research. However, the prevailing theory points towards problems with the placenta itself specifically, issues with its proper development or inadequate blood flow to it right from the early stages of pregnancy. It's thought that the blood vessels in the placenta might not develop correctly, leading to reduced blood flow between mother and baby, triggering a kind of systemic inflammatory response throughout the mother's body. Genetic factors are also definitely believed to play a role. We sometimes see it run in families.
What about stress? Does that cause it?
It's crucial to clarify that stress, while it can impact overall well-being and blood pressure generally, is not considered a direct cause of preeclampsia itself. We do categorize risk factors, though, to help identify individuals who need closer monitoring. High-risk factors include things like having had preeclampsia in a previous pregnancy, carrying multiples like twins or triplets, having chronic high blood pressure before pregnancy, existing kidney disease, diabetes, pregestational, or certain autoimmune conditions like lupus.
Are there other, maybe less obvious risks?
Yes, there are also moderate risk factors which are important. These include being pregnant for the very first time, having a really long gap, say more than 10 years between pregnancies, having a body mass index, BMI, over 30, a family history of preeclampsia, even if you haven't had it yourself, or being age 35 or older. Complications in past pregnancies, like delivering a baby with low birth weight or conceiving through in vitro fertilization, IVF, also slightly increase the risk. And unfortunately, there are clear disparities related to race and socioeconomic status that contribute to an increased risk, highlighting systemic issues in healthcare access and quality. But again, it's important to remember preeclampsia can sometimes develop in individuals with no known risk factors at all.
Okay. What are the serious consequences if preeclampsia isn't properly managed or caught early? It sounds like it can escalate pretty quickly.
The complications of unmanaged or severe preeclampsia can indeed be very serious, impacting both the mother and the baby. For the mother, the most feared complication is the progression to eclampsia, which involves seizures. That's the condition we'll discuss next. Other serious potential outcomes include significant liver damage, stroke, coma, heart failure, severe lung problems due to fluid buildup, pulmonary edema, kidney failure, or internal bleeding like HELOP syndrome, which we'll also cover. And importantly, in the long term, individuals who have had preeclampsia face an increased lifetime risk of cardiovascular disease, kidney disease, and stroke, sometimes years or even decades after the pregnancy.
And for the baby.
For the baby, preeclampsia often necessitates premature birth because early delivery is frequently the only way to resolve the condition and protect the mother. This prematurity carries its own set of significant risks, including breathing and feeding difficulties, potential developmental delays, and often requires extended stays in the neonatal intensive care unit, the NICU. Preeclampsia can also lead to fetal growth restriction, where the baby doesn't grow as expected because the placenta isn't delivering enough oxygen and nutrients effectively. Another serious risk is placental abruption, where the placenta separates from the uterus too early. This can be life-threatening for the baby, and in the most severe unmanaged cases, preeclampsia can tragically lead to stillbirth.
So, how do medical professionals identify preeclampsia, and what are the main strategies for managing it once it's found?
Preeclampsia is often first suspected and then identified during those routine prenatal appointments. Consistent blood pressure checks are absolutely key, as are those urine tests for protein. If these initial screenings raise red flags, further diagnostic steps are taken. These usually include more detailed blood tests to check platelet levels and assess kidney and liver function markers. A 24-hour urine collection might be done to precisely measure the amount of protein being lost. Ultrasounds and other fetal monitoring techniques like non-stress tests or biophysical profiles are also crucial to assess the baby's growth, well-being, and blood flow through the umbilical cord, making sure they aren't in distress.
And treatment? Is it just delivery?
The approach to treatment is highly individualized. It depends significantly on how severe the condition is and how far along the pregnancy is the gestational age. But yes, the only definitive resolution for preeclampsia is the delivery of the baby and the placenta. If the pregnancy is close to full term, typically 37 weeks or later, an early delivery, either through induction of labor or sometimes a C-section, is often recommended as the safest course. If it's diagnosed much earlier in the pregnancy, the goal shifts to trying to prolong the pregnancy as safely as possible, giving the baby more time to develop. This involves very close monitoring, frequent appointments, regular blood pressure checks, sometimes even at home, and repeated blood and urine tests.
Are there medications used?
Yes, medications are a key part of management before delivery in many cases. Drugs might be given to carefully lower blood pressure and prevent it from reaching dangerously high levels. If preterm delivery looks likely, corticosteroids are often given to the mother. These help accelerate the baby's lung maturity, preparing them for breathing outside the womb. And critically, during labor and delivery, and often for about 24 hours afterward, magnesium sulfate is frequently given intravenously. This powerful medication is crucial for preventing seizures, preventing the progression to eclampsia.
Given how vital early detection is, what are your thoughts on expectant parents tracking their blood pressure at home, even if they feel perfectly fine? Is it a crucial tool for vigilance, or could it potentially add unnecessary stress to an already anxious time? What's your take? You can share your perspective with us in the comments.
That's a really relevant question today. From my perspective, I believe home blood pressure monitoring can be incredibly important, especially for those identified as having moderate or high risk factors. While yes, it might feel like another task, early and consistent detection of rising blood pressure, even without obvious symptoms, can be genuinely life-saving. It provides valuable real-time data that empowers individuals to be proactive partners in their own care and allows their healthcare providers to make informed decisions much more quickly. I think the benefits of early detection often outweigh the potential for added stress in many cases.
I see the value in early detection, absolutely, but I also think for some people, maybe those at lower risk initially, the routine of daily home monitoring might create significant anxiety, potentially making a normal pregnancy feel more medicalized or stressful than it needs to be. Perhaps for the general pregnant population, focusing intensely on knowing the key warning symptoms and ensuring consistent attendance at regular prenatal visits where professionals are doing the monitoring is sufficient. Maybe reserving routine home monitoring for those specifically identified as being at higher risk offers a better balanced vigilance without potentially overwhelming everyone. It's a nuanced issue. You've mentioned eclampsia now a couple of times as the most severe progression of preeclampsia. Let's delve into that. Number 3, eclampsia. What makes eclampsia distinctly different from preeclampsia, and just how dangerous is it for both mother and baby?
Right. Eclampsia. It represents the most severe and immediately life-threatening complication of preeclampsia. It's specifically characterized by the sudden onset of seizures, convulsions in someone who has preeclampsia. While it typically happens in those already diagnosed with preeclampsia, it's vital to know that in rare cases, it can develop in someone who wasn't previously diagnosed. It is an undeniable medical emergency. Its danger lies in the very real potential for severe injury, permanent disability, or even death for both the pregnant person and the baby. Eclampsia signifies that the preeclampsia has progressed to the point where the brain's function is severely affected, leading to those dangerous seizures.
When does eclampsia typically occur, and what are the hallmark signs that medical teams or even family members should be acutely aware of?
Eclampsia most commonly shows up during the final trimester of pregnancy, generally from around 28 weeks onwards, or critically, during labor and delivery itself. However, and this is a lesser known but crucial point, eclampsia can also strike after birth up to 6 weeks postpartum. The highest risk period postpartum is actually within the first week, often just 1 to 2 days after delivery. This postpartum possibility is why continued vigilance is so important even after the baby arrives.
And the signs. It's mainly seizures, right?
Yes, the most definitive symptom, the thing that defines eclampsia, is the occurrence of generalized seizures, often tonic-clonic seizures. These typically last anywhere from 1 to maybe 2 minutes. During a seizure, individuals might experience rapid facial twitching, then powerful body-wide muscle contractions and relaxations. Foaming at the mouth can happen. They will typically lose consciousness during the seizure. Afterwards, upon regaining consciousness, they may be very confused, disoriented, or agitated, and often have no memory of the seizure itself. Seizure-related complications can be severe, biting the tongue, head trauma from falling, even broken bones from the force of the muscle contractions.
Are there warning signs before a seizure?
Yes, sometimes. Prior to a seizure, individuals might experience specific warning signs or prodromes. These can include those severe, persistent headaches we talked about with preeclampsia, visual disturbances like blurry or double vision, seeing spots or flashing lights, confusion, intense pain in the upper right side of the belly, liver pain, severe nausea or vomiting, or sometimes a rhythmic twitching of the angle called clonus. Recognizing these potential warning signs is crucial for trying to intervene before a seizure occurs, if possible.
What are the underlying factors that lead to eclampsia, and who might face a higher risk of developing this really severe complication?
Like preeclampsia, the exact why isn't fully understood, but it's believed to be closely linked to the same core issues: problems with how the placenta developed, or inadequate blood flow. This cascade leads to widespread inflammation and blood vessel dysfunction throughout the body, including the brain. Genetic factors are also thought to play a role, as are inflammatory changes, potential abnormalities in blood clotting, or even direct inflammation within the brain itself. All these things contribute to making the central nervous system vulnerable to the seizure activity.
And the risk factors, are they the same as for preeclampsia?
Largely, yes. The risk factors overlap significantly with those for preeclampsia. Being pregnant for the first time, carrying multiples, having a personal or family history of preeclampsia or eclampsia, these are big ones. Age is also a factor, with higher risks seen in teenagers and also in individuals over 35. A history of fetal growth restriction or stillbirth in a previous pregnancy or placental abruption can increase susceptibility. Other factors include obesity, pre-existing diabetes, autoimmune conditions like lupus, or having chronic high blood pressure before pregnancy. And, as mentioned before, getting pregnant through IVF has also been linked to a somewhat higher risk.
So how is eclampsia definitively identified in an emergency, and what does that immediate, urgent medical care look like?
Eclampsia is diagnosed clinically, meaning based on the symptoms. When a pregnant or postpartum person, usually someone known to have preeclampsia, starts experiencing seizures that can't be explained by another cause, like epilepsy, that's diagnosed as eclampsia. In an emergency, medical professionals prioritize immediate treatment above everything else. While knowing about a prior preeclampsia diagnosis or family history is helpful, they absolutely do not delay life-saving care waiting for a detailed history. Once the patient is stabilized, diagnostic tests will likely confirm the high blood pressure and protein in the urine, and blood tests check liver function, blood cell counts, and clotting ability. Sometimes imaging, like a CT scan of the head, might be done later to rule out other serious issues like a stroke or brain hemorrhage that could mimic or result from eclampsia.
And the immediate care, what's done right away?
Immediate care is absolutely crucial and needs to be fast and decisive. The patient is promptly given magnesium sulfate intravenously. This is the specific first-line anti-seizure medication used for eclampsia. Its main job is to stop current seizures and prevent more from happening. During the seizure itself, the patient is carefully positioned on her side to reduce the critical risk of aspiration, inhaling vomit, or fluids into the lungs. If, in rare cases, magnesium sulfate isn't effective, other anti-seizure medications might be used. Medications to safely lower dangerously high blood pressure are also given, along with supplemental oxygen to ensure adequate oxygen supply for both the patient and the baby.
And then delivery.
Yes. Ultimately, the most effective way to resolve, or essentially cure, eclampsia is the delivery of the baby and the placenta. Once the patient is stabilized and the seizures have stopped, delivery is typically recommended without significant delay. A C-section is often preferred because it's usually faster, which can minimize potential complications and ensure a quicker resolution. However, a vaginal birth might still be considered if the patient and baby are stable and labor is already progressing well. After delivery, the magnesium sulfate or other anti-seizure medication is typically continued for at least 24 hours to prevent any further complications, like more seizures or rebound high blood pressure as the body starts to recover.
What are the potential long-term outcomes for those who experience eclampsia beyond the immediate crisis? Does everything just go back to normal?
While most individuals who experience eclampsia do recover and safely deliver their babies, the long-term outlook needs careful consideration. Serious complications can, unfortunately, occur in a significant percentage of cases, maybe somewhere between 5% and 14%. For the mother, these can include severe outcomes like stroke, lasting heart failure, or kidney issues. For the baby, the primary risks are tied to premature birth breathing problems, feeding issues, developmental concerns, but also potential brain injury or breathing difficulties, specifically related to the eclamptic event or difficult delivery. Sadly, in a small minority of cases, eclampsia can be fatal for the mother, the baby, or both, which really underscores its critical nature.
What about after recovery?
Beyond the acute phase, some individuals might continue to have high blood pressure for 6 to 8 weeks after pregnancy, requiring ongoing monitoring and sometimes medication. There's also a definitely increased risk of developing preeclampsia or eclampsia again in future pregnancies, so low-dose aspirin might be recommended preventatively. Furthermore, studies show that individuals who have experienced eclampsia have an increased long-term risk of cardiovascular disease, potentially other seizure disorders, and maybe even cognitive impairment later in life. This highlights the profound, lasting impact this condition can have, making long-term follow-up really important.
This really underscores the need for immediate, decisive action. Okay, another scenario for our listeners. If you were a medical professional in a busy delivery ward and you saw patients showing subtle signs of preeclampsia that could escalate to eclampsia knowing how fast things can change, would you prioritize immediate aggressive intervention or would you monitor very closely and wait for clearer signs before acting? What's your approach in that high-stakes moment? Share your thoughts in the comments.
That's a tough judgment call clinicians face. Given the potential for rapid and devastating deterioration with eclampsia, my personal stance would always lean towards immediate, decisive intervention, even with relatively subtle signs, if they are clearly progressing or concerning in context. The risks associated with waiting for clearer, more severe signs often far outweigh the risks of early, appropriate action. Preventing the seizure is paramount. So early intervention for me feels like the safest approach to prevent the worst outcomes.
I understand that drive to act quickly, especially given the stakes. My approach, however, might lean more towards very close, continuous monitoring with a very low threshold for escalation. While immediate full intervention for truly subtle signs might have its own consequences, like unnecessary early delivery, the absolute key is rapid escalation if any signs worsen or new ones appear. It's about being acutely ready to act decisively, but ensuring the actions taken are proportionate to the evolving clinical picture based on constant reevaluation. So, less about immediate full intervention for the very first subtle sign, more about rapid, definitive action the moment things clearly shift. It's a dynamic balance. Our intervention for the very first subtle sign, more about rapid, definitive action the moment things clearly shift. It's a dynamic balance. Our journey into these critical childbirth complications continues. Let's explore number 4. HELLP syndrome. The name itself, an acronym, tells us it's a condition affecting different systems in the body. What exactly does HELLP stand for, and how serious is this one?
Right, HELLP syndrome. It's indeed named after its key laboratory findings, which are crucial for understanding its impact. HELLP stands for hemolysis, which means the breaking down of red blood cells, the cells vital for carrying oxygen, elevated liver enzymes, indicating significant stress or damage to the liver, and low platelets, meaning a dangerously reduced number of those tiny cells that help your blood clot, putting you at high risk for uncontrolled bleeding. HELP syndrome is a rare but extremely life-threatening pregnancy complication. It's often considered a severe variant or complication of preeclampsia, but what makes it particularly insidious and challenging is that it can develop without the typical high blood pressure and protein in the urine that we usually associate with preeclampsia.
Say no high blood pressure.
Not always. Only about 80% to 85% of people with HELLP actually present with those classic signs. This lack of typical preeclampsia markers makes its diagnosis incredibly challenging and often dangerously delayed. Early and accurate identification is absolutely critical because serious illness, and even death, can tragically occur in about 25% of cases if the condition isn't managed promptly and effectively. It can be a very silent, very rapid threat.
When does HELLP syndrome typically show up, and what are its symptoms, especially given you said it can be hard to identify?
HELLP syndrome most commonly occurs before delivery, usually between 27 and 37 weeks of pregnancy. However, and this is a really critical point, about 15% to 30% of cases first appear after delivery, often within the first 7 days postpartum. This post-delivery onset can be particularly deceptive, as many women are already home and thinking they're on the road to recovery. The symptoms themselves can initially mimic other common, much less severe conditions, like the flu or maybe gastritis, which contributes significantly to the difficulty in catching it quickly.
So what's the main thing to look for?
The hallmark symptom, the one that should raise immediate serious concern, is severe epigastric, upper abdominal, or upper right quadrant pain. This is where the liver is located. This pain, often described as intense, burning, or aching, is present in a wide range of cases, maybe 40% up to 100%, and it's usually caused by the liver swelling or distending. Other common symptoms include persistent nausea, vomiting, or indigestion, especially if they are severe or happen along with that abdominal pain. Headaches that are persistent and don't go away even with pain medication are another warning sign. Individuals might also experience just a generalized feeling of malaise or simply feeling profoundly unwell, like they're coming down with something serious. The swelling, particularly of the face or hands, and changes in vision, blurry vision, seeing double flashing lights are also important potential signs. Less commonly, you might see jaundice, yellowing of the skin or eyes, or unusual bleeding or bruising due to the low platelets. And beyond these symptoms people feel, the crucial diagnosis comes from medical blood tests which reveal those measurable signs. The high blood pressure, if present, protein in the urine, if present, those significantly increased liver enzymes like AST and LDH, the critically decreased platelet counts, and clear laboratory evidence of red blood cell breakdown, hemolysis.
Given how tricky it can be to diagnose based on symptoms alone, what are the underlying factors that contribute to ACLLP syndrome, and who faces a higher risk?
Well, while ACLLP syndrome is often considered a variant or severe progression of preeclampsia, the exact underlying reasons why it develops in certain individuals are still not entirely known, even within the medical community. There isn't one single clear-cut cause we can point to for everyone. However, we have identified several significant risk factors that definitely increase an individual's susceptibility to this dangerous condition. These risk factors include having had a previous diagnosis of preeclampsia or eclampsia in an earlier pregnancy, or having a family history of either preeclampsia or HLP syndrome. Certain pre-existing autoimmune conditions or clotting disorders can also increase the risk. Other demographic and health factors play a role too. Things like white ethnicity, maternal age over 35, obesity, chronic high blood pressure that existed before pregnancy, pre-existing diabetes, or even a history of migraines have been linked. Carrying multiple babies, like twins or triplets, significantly heightens the risk due to the increased physiological demands. Abnormal placentation, such as a molar pregnancy, can also be a contributing factor. But, and this is vitally important, HLLP syndrome can occur in individuals with absolutely no known risk factors. This really underscores why vigilance and prompt investigation of concerning symptoms are crucial for everyone, not just those we label as high risk.
How do medical professionals definitively identify HLLP syndrome then, and what does the urgent care plan look like once it's finally diagnosed?
Okay, due to its potential for rapid and severe progression, HELLP syndrome should be strongly considered and actively investigated in any pregnant person in the second half of pregnancy or immediately after birth who presents with that new onset, significant epigastric or upper right abdominal pain until it's definitively ruled out. You have to think HLLP until proven otherwise in that scenario. The diagnosis relies heavily, almost entirely, on specific blood tests that confirm that characteristic triad of the syndrome.
The HELLP parts.
Exactly. Those crucial blood tests look for clear evidence of hemolysis. Things like elevated bilirubin levels, high LDH and AFT enzymes, or specific findings of damaged red blood cells on a blood smear, along with worsening anemia. They also confirm significantly elevated liver enzymes, AST and ALT levels, are typically way up, maybe above 70 IUL, or at least twice the upper limit of normal. And critically, they look for a low platelet count, specifically below 100,000 per cubic millimeter. We also use classifications for severity class 1, 2, or 3 based on just how low the platelets are and how high the liver enzymes go. Lower class numbers like class 1 actually indicate a more dangerous and severe situation.
And the urgent care, what's the plan?
Urgent care is absolutely paramount. The goal is to arrest the progression of the disease immediately and significantly reduce the risk of bad outcomes. The definitive solution, and usually the primary treatment once HELP is diagnosed, is the delivery of the baby in the placenta. That's the only way to stop the underlying process causing the syndrome. Intravenous magnesium sulfate is administered, just like in severe preeclampsia and eclampsia, to prevent seizures, which can also occur with HELP. Intravenous corticosteroids, like dexamethasone, might also be used. They can help accelerate the baby's lung development if preterm delivery is necessary. And some evidence suggests they might also help improve the mother's platelet count and liver function, although this is debated. Blood pressure is meticulously controlled to prevent severe hypertension. And critically, blood product replacement transfusions of red blood cells, platelets, or plasma may be urgently needed to manage severe anemia, control bleeding due to low platelets, and address clotting issues.
What are the serious consequences of HELLP syndrome for both mother and baby, and what's the long-term outlook for those who survive it?
The consequences of CHLP syndrome can be quite devastating, really reflecting its severe nature. For the mother, it can lead to immediate life-threatening complications like liver rupture or internal bleeding, including bleeding into the brain of stroke. It can also cause acute heart or kidney failure, or even necessitate the patient being placed on a breathing machine in intensive care. For the baby, the outcomes depend heavily on their gestational age at delivery. If the baby weighs over 1,000 grams, which is roughly 2 pounds, at birth, the survival rate is generally similar to other babies born prematurely at that size. However, for babies born very prematurely or weighing less than 1,000 grams, there's a significantly higher chance of needing ventilator care and a much longer hospital stay due to the complications of extreme prematurity. Tragically, the stillbirth rate associated with HLLP syndrome can be substantially higher than with severe preeclampsia or eclampsia alone, often linked to complications like severe placental abruption triggered by the HALP or just the extreme prematurity itself.
And long-term, any future pregnancy risks?
Yes. Looking ahead to future pregnancies, individuals with a history of HELLP syndrome face a significantly increased risk of developing preeclampsia. Again, rates range widely, maybe 16% to 52%, or even having recurrent HELLP syndrome itself, which happens in about 2% to 19% of subsequent pregnancies. This means very careful monitoring and potentially preventative strategies in future pregnancies are absolutely essential.
Okay, another thought experiment for our listeners. Imagine you are a medical professional, you have a patient with suspected HELLP syndrome, which you know needs urgent, aggressive care, but you also know there's another colleague on staff who is generally known to be very conservative in their approach to interventions. How do you ensure your patient gets the urgent care HELLP demands, even if it might conflict with that colleague's usual practice? What would you prioritize in that moment? Share your strategies with us in the comments.
In a clearly life-threatening situation like rapidly progressing HELLP syndrome, my absolute priority has to be patient safety above all else. That means I would immediately escalate the situation, clearly communicate the urgency based on objective data, and ensure the patient receives the established gold standard aggressive care that HELLP requires. If necessary, this might mean firmly advocating within the team, citing guidelines, or even involving a higher clinical authority to ensure timely and appropriate action. Patient survival overrides practice-style differences in emergencies.
I agree, patient safety is paramount. My approach would focus heavily on clear, concise communication of the objective evidence, the lab results showing rapid deterioration, the known severe risks of delaying intervention in HELLP. I'd emphasize the established medical protocols and clinical guidelines that mandate urgent action in this scenario. It's about presenting the undeniable evidence for urgent intervention, grounding the need for action in established best practice rather than making it about conflicting personal preferences. The goal is to align everyone on the critical path based on the data. All right, our final deep dive for today brings us to number 5, placenta accreta. This condition sounds like it's all about how the placenta attaches, or maybe more accurately, overattaches. Can you explain what placenta accreta is exactly and how it differs from a normal, healthy placental attachment?
You've got it. Placenta accreta is indeed about an abnormal and dangerously deep attachment of the placenta to the uterine wall. Normally, after the baby is born, the placenta detaches easily and cleanly from the uterine wall and is expelled. It's usually a natural, straightforward process. But with accreta, part or sometimes all of the placenta remains abnormally, often inseparably attached. The little fingers of the placenta, the villi, grow too deeply into the uterine wall. Attempting to manually remove it, or even just its natural detachment process, can tear into the uterus and cause incredibly severe, life-threatening bleeding or hemorrhage right after delivery. It's honestly one of the most feared and serious complications we face in obstetrics.
You said it's a spectrum.
Yes, exactly. It's important to understand that placenta accreta exists on a spectrum of conditions, ranging in severity based on just how deeply the placenta invades the uterine wall. The most common, and often considered the mildest form, is placenta accreta itself. In this case, the placental villi attach firmly to the uterine wall surface layer, the endometrium. but don't significantly invade the actual uterine muscle, the myometrium. Next, there's placenta increta. This is an intermediate form where the placenta grows more deeply into the uterine muscle wall. This accounts for maybe 15% of cases. And then the most severe form is placenta procreta. Here, the placenta grows entirely through the uterine wall, potentially invading nearby organs like the bladder or the intestines. This occurs in about 5% of cases and is extremely dangerous, often requiring complex surgery involving multiple specialists. Sometimes it can be really challenging for us to determine the exact depth of invasion with certainty until the moment of delivery.
That distinction really helps understand the severity levels. It seems like we're hearing more about placenta accreta lately. Why is this condition becoming more common, and who is most at risk for this kind of deep attachment?
You're absolutely right. The occurrence of placenta accreta has significantly dramatically increased over the past few decades. It's a major public health concern in obstetrics worldwide.
Hmm.
To give you some perspective, it affected only about 1 in 30,000 pregnancies back in the 1960s. By recent estimates, like around 2016, that rate had skyrocketed to maybe 1 in every 272 pregnancies. That's a huge jump.
Why such a big increase?
The main reason for this sharp increase is directly linked to the rising rates of cesarean sections, or C-sections. Prior uterine surgeries, especially C-sections, cause scarring on the uterine wall. In a subsequent pregnancy, if the embryo happens to implant over or near one of these C-section scars, the placenta can attach abnormally deeply into that scar tissue or directly into the underlying muscle, instead of the healthier normal uterine lining, the decidua, which is designed for easy separation. This makes it extremely difficult or impossible for the placenta to detach properly after birth. Other uterine surgeries that cause scarring also increase the risk, things like surgical removal of fibroids, myomectomy, certain hysteroscopic surgeries inside the uterus, uterine artery embolization, pelvic radiation therapy, or endometrial ablation procedures.
So previous C-sections are the biggest risk.
By far, the risk of placenta accreta increases significantly with each prior C-section. For example, the risk is relatively low, maybe 0.3% after just one C-section, but it can rise steeply to 6.7% or even higher after 5 or more C-sections. That's a massive increase in risk. Another major risk factor is placenta previa, which is when the placenta implants low in the uterus, partially or completely covering the cervix. Previa is very strongly linked with accreta. It's present in about 80% of placenta accreta cases. The combination of a previous C-section scar and placenta previa is particularly high risk. Other risk factors include maternal age over 35, the number of previous childbirths, the risk generally increases with parity, conceiving through in vitro fertilization, IVF, and a rare condition called Asherman syndrome, which involves scar tissue formation inside the uterus, usually from previous surgeries. But again, importantly, some individuals develop placenta accreta without any of these known risk factors.
So, if most people don't have symptoms during pregnancy, what are the subtle signs, if any, that might indicate placenta accreta? And how is it typically identified by medical professionals before delivery happens?
That's one of the toughest parts. Most individuals with placentic accreta experience absolutely no symptoms at all during their pregnancy. This makes early diagnosis completely dependent on high-quality prenatal screening, usually with ultrasound. In very severe cases, particularly with placenta procreta, where the placenta has grown through the uterus and might be pressing on or invading nearby organs, there might be symptoms like persistent pelvic pain, or maybe, in rare instances, blood in the urine if the bladder is involved. If placenta previa is also present, which remember is common, then vaginal bleeding might occur in the third trimester. However, this bleeding is usually considered a symptom of the previa itself, not necessarily the accreta, though it often triggers the ultrasound that finds the accreta.
So it's usually found on ultrasound.
Yes, exactly. Because of this typical lack of symptoms, diagnosis is primarily made through advanced imaging. It's often first suspected during a routine second trimester detailed anatomy ultrasound, or sometimes on later growth scans, maybe around 27 to 29 weeks, or even earlier if risk factors are high. If an ultrasound suggests accreta, then a magnetic resonance imaging scan, an MRI, might be used to get a more detailed picture of how deeply the placenta has grown into the uterine wall, and to check if it seems to be involving other organs, especially the bladder. However, even with the best ultrasound and MRI technology, it can still be challenging to fully determine the exact extent of the invasion before surgery. This is why a significant number of cases, maybe 40% to 50%, are only definitively diagnosed during the delivery, typically when the placenta simply fails to detach normally within the expected time frame, usually about 30 minutes after the baby is born.
This unexpected diagnosis during a critical moment makes managing the situation much more urgent and complex.
What are the potential outcomes then? And what is the crucial medical care plan when placenta accreta is diagnosed, especially given those severe risks you mentioned?
The biggest problem with placenta accreta, as we've established, happens right at the time of delivery because the placenta won't detach properly. For the baby, this condition itself doesn't directly harm them while they're growing. However, it often necessitates a planned early delivery, typically scheduled via C-section, somewhere between 34 and 37 weeks gestation. So, 3 to 6 weeks before the due date to minimize the risk of unexpected labor and catastrophic bleeding for the mother. This planned preterm birth increases the baby's risk of needing NICU admission due to prematurity, but it's done for maternal safety.
And the risks for the mother are the main concern.
Yes, the main complications are for the mother, and they can be extremely serious, even life-threatening. The most significant risk, the one we plan everything around, is severe hemorrhaging, excessive, uncontrolled bleeding during the delivery attempts or hysterectomy, which can be massive and incredibly rapid. Because of this bleeding risk, a hysterectomy, the surgical removal of the uterus, is often the only definitive and safest way to manage the bleeding and remove the placenta successfully. This tragically means no future pregnancies are possible. This procedure is usually a planned cesarean hysterectomy where the baby is delivered via C-section and then the uterus is removed immediately afterward, often with the placenta still attached inside it to minimize blood loss. Other potential complications for the mother can include damage to surrounding organs like the bladder or intestines during the complex surgery, severe blood clotting problems, DIC again, lung or kidney failure due to massive blood loss and transfusion reactions, and, in severe cases despite all efforts, death.
How is care managed? It sounds like it needs a big team.
Absolutely. The care and management for suspected or confirmed placenta accreta require a highly specialized multidisciplinary approach. Delivery should always be planned and performed in a major hospital, a tertiary care center that has experienced specialists and a full team ready 247. This team typically includes maternal-fetal medicine specialists, experienced obstetric surgeons, often gynecologic oncologists or urologists if organ invasion is suspected, skilled anesthesiologists used to managing massive hemorrhage, a well-equipped blood bank with significant blood product reserves readily available, and expert NICU staff ready for a preterm baby. Antenatal corticosteroids are usually given to the mother before the planned early delivery to help accelerate the baby's lung maturity.
Is hysterectomy always the only option?
In most cases, especially in creta and precreta, it's the safest option. In very rare, carefully selected situations, usually with milder forms, focal decreta, and if the person strongly desires future fertility, medical professionals might attempt a conservative approach. This involves leaving the placenta or parts of it inside the uterus after the C-section, hoping it will gradually resorb or dissolve over weeks or months. However, this approach carries significant risks of severe infection, delayed hemorrhage, and often still ends up requiring a hysterectomy later anyway. It's not standard practice. It's absolutely crucial to understand that attempting a vaginal birth if placenta accreta is present but undiagnosed is extremely dangerous and can lead to immediate, catastrophic, life-threatening blood loss.
What's recovery like?
Recovery from a delivery complicated by placenta accreta, especially if it involves a cesarean hysterectomy and significant blood loss, can be much more intense and prolonged than after a standard delivery. Patients often require a stay in the intensive care unit, ICU, for a day or two for close monitoring. The total hospital stay is frequently longer, maybe 3 to 5 days or more. Comprehensive pain management and careful follow-up are crucial. Beyond the physical recovery, many individuals experience significant psychological effects, anxiety, depression, or post-traumatic stress disorder, PTSD, particularly related to the traumatic nature of the surgery, the emergency situation, and especially if a hysterectomy was necessary, leading to grief over lost fertility. Support for this is vital. Despite its life-threatening potential, the good news is that with accurate prenatal diagnosis, meticulous planning, and expert care from a dedicated multidisciplinary team, the maternal survival rate for placenta accreta is generally high, often quoted around 93% or higher in specialized centers.
This condition really does highlight the incredible fragility of life and the immense strength, both physical and emotional, required during childbirth sometimes. Okay, last question for our listeners today. If you are a medical professional facing a patient with a diagnosed severe case of placenta accreta, knowing the high risk of hemorrhage and the very high likelihood of a necessary hysterectomy, how would you approach preparing the patient and their family for what might be the most challenging experience of their lives? How do you balance that difficult transparency with maintaining hope? What's your advice on navigating that complex conversation? Please share your thoughts in the comments.
That's one of the hardest conversations we have. My priority in that situation would be absolute, but empathetic transparency. I would need to clearly explain the gravity of the diagnosis, the reasons why a cesarean hysterectomy is almost certainly the necessary and life-saving procedure, and the potential complications involved. But alongside that stark reality, I would strongly emphasize the expertise and preparedness of our entire multidisciplinary team, our detailed plan, and our unified goal: ensuring the parent's life and the baby's safety above all else. It's about providing realistic, honest information to allow for informed consent and mental preparation while still conveying confidence in the team's ability to manage the situation and achieve the best possible outcome, which is usually survival. It's about compassionate realism.
I agree completely with transparency and compassion. I think my focus would also be on empowering the patient and their family, even in such a difficult situation. This means clearly outlining not just the recommended plan, the cesarean hysterectomy, but also the reasoning behind it. Maybe explaining why other options are too risky. Crucially, I would also want to proactively highlight and connect them before the delivery with the long-term support systems available, psychological support, peer support groups, acknowledging the profound emotional and psychological impact, especially regarding fertility loss. Recognizing that physical survival is only the beginning of the recovery journey, and validating the emotional toll is just as important as the medical plan itself. Well, we have explored some of the most challenging and frankly devastating complications that can occur during childbirth and the postpartum period. Postpartum hemorrhage, preeclampsia, eclampsia, HLLP syndrome, and placenta accreta. Understanding these conditions isn't just for doctors and nurses. It's truly vital information for anyone who might become pregnant or who loves and supports someone navigating pregnancy and birth.
They are undeniably complex conditions, absolutely. But knowing the potential signs and symptoms, understanding a little bit about why they happen, and recognizing the critical need for immediate medical attention can genuinely make a life-saving difference in outcomes. Early identification and proper decisive care are just paramount.
We really hope this deep dive has given you a clearer picture of these serious challenges and, most importantly, empowered you with knowledge that could one day be crucial. Thinking about everything we've discussed today, what aspect of care for these complications do you believe needs the most public awareness? Or maybe what specific thing surprised you most during our conversation?
Yeah, what do you think needs more focus or understanding out there? We'd love to hear your thoughts in the comments below.
Thank you so much for listening. Please subscribe if you haven't already. And as always, have a nice day or a good night and stay safe. See you on the next one.